guys know me, I'm Danielle Roberts. I'm the Associate Chief of Education for Winship. I'm a PA, and I really appreciate the opportunity to come back. How many of you guys saw my talk last year? All right, did you find me slightly entertaining? Yes. All right, so I'm gonna hope I'm not a one-hit wonder. We're gonna hope that the sequel can be just as good as the original. You know, The Godfather Part 2 has gone down as one of the best sequels of all time. Probably not Godfather level, but we're gonna do our best today. All right, I asked you guys to do some pre-conference questions, and this was just for me to have an opportunity, one, to know my audience, but also get an idea of where you think you are from understanding oncologic emergencies. And so that was just, if anybody wanted a chance to do it real fast. That's who I am. I don't have any conflicts of interest or disclosures. So by the end of the talk, you should be able to identify the most common oncologic emergencies. You should be able to order the tests and order the appropriate treatments. And so I asked you to do this pre-conference questionnaire, and 56% of you guys said that you can recognize an oncologic emergency, which is fantastic. And that's what I would expect for the roles that you guys all do. Also, that's gonna make this a whole lot more fun today. So I want this to be very interactive. I want you guys to shout out your answers, your questions. It's boring listening to me talk all by myself up here and staring at PowerPoint presentations. One of the other questions for the pre-conference questionnaire was, what is your role? And the vast majority of you guys are nurses within different phases of our oncologic units here. And I work with a lot of you guys, so thank you guys for all coming and supporting the conference. The other question was, what are the most common emergencies in hematology and oncology, and name 3? So can anybody name their number one that you can answer that you would find just like that? I love it. So yes, tumor lysis syndrome, neutropenic fevers, you guys will all be able to recognize those without any problems. So we're probably not going to talk about those today. And then I asked, if you only could choose one medication to treat most emergencies in oncology, what would it be? I love it. Yes. All right, so we're going to talk more about that. And there's not one right or wrong answer, but as we go through and we start talking about these, if you have to pack your jump bags, which we're going to do, and you have to pick only a couple of items to take with you, what are going to give you your most bang for your buck? And I think you guys all know me well enough to know that I love steroids, and steroids go a long way for treating most of our oncologic emergencies. All right. Okay, so why is this important? This is important because there is, and this slide is wrong, in the year of 2020, there was estimated 1.9 million new cases of cancers were diagnosed in the US in 2022. And it's important that we understand that because a lot of these patients present in our emergency rooms or present in our clinics with these oncologic emergencies. And 1.9 million, that's a lot. However, cancer mortality rates have been decreasing with an average of decline of 1.8% per year for men and 1.4% per year for women. And this is all thanks to what you guys do. So you guys should pat yourselves on the back. You guys are doing a phenomenal job. And we're doing a really good job of taking care of these really special patient population. So we should all be proud of the work that we do. As these cancer numbers continue to decline, the number of survivors that we have are increasing as well too. So in January of 2019, there was estimated 16.9 million cancer survivors with an expected increase of 22 million by the year of 2030. Again, you guys should be so proud of the work that you do. You guys know this, I love, love, love what I do. I love our oncology patients. And the fact that we're actually having more survivors every single year and that number is growing is an amazing thing. But there are bumps along the road, and that's what we're going to talk about today. So some oncologic emergencies are insidious. They can take months to develop, whereas others manifest over hours, causing significant mortality or morbidity. Prompt identification of these emergencies and timely intervention can improve survival, and it can also improve quality of life. So can anybody guess what the most common oncologic emergency disease, so what is the underlying cancer that presents in the emergency room? So they've gone to the emergency room, they've got an oncologic emergency. What's their underlying cancer? Lung cancer, what else? Lymphomas? Anybody else? Leukemia. All right, so yes, your leukemias are gonna be 31% of patients presenting of those new diagnoses or diagnoses seen by oncologic emergencies in the emergency room. 31% of those underlying diagnoses are gonna be due to AML. Pancreatic cancer comes in second at 30%, but really can be just about anything. And so emergently diagnosed cancers account for somewhere between 11 and 29% of newly diagnosed cancers, and they're associated with a lower 1-year survival rate, increased hospitalization rates, and a poorer quality of life compared to cancers diagnosed during routine primary care. Can you guys think of any reasons why that is? Correct, they're more advanced. And so, again, why am I bringing all this to your attention? Because it goes into, I think, the meat of this talk, which is, one, we need to be able to understand the underlying disease, be able to treat the underlying disease, but we need to be able to recognize those oncologic emergencies. All right, so last year, Naked and Afraid came to us and they were like, you know what, let's send all of your, or some of your cancer patients on a 2-week adventure to an island, and you had to be the medical provider while you were there. Well, this subset of cancer survivors said, you know what, I don't really like the beach. How many people like the mountains over the beach? Yeah, there's a handful of us, right? Beach is not for everybody. And so this group came to Naked and Afraid and they said, you know what, we want to go somewhere else and we want it to be a little bit more intense. And so Naked and Afraid said, you know what, our viewership is kind of declining. We're not really relevant on TV anymore, so let's see what else we can do. How many of you guys actually watch Naked and Afraid? Yeah, it's one of my favorites. How many watch Alone? Yeah, that's one I'm big into right now. And so what's unique about all these shows is they all have medical providers that are on these shows, right? So you are actually there, you are being called to the scene when you're having an oncologic emergency, and just like the survivors that have to pack their bags, you have to pack your jump bag. So you were like, last year was rough, right? It was 2 weeks, there was a lot that you took care of, but they said, you know what, we're only gonna do it for 1 week this year, and you're like, okay, I'm gonna do it, I can do it, so we're gonna go to the mountains. So you gotta pack your jump bag. And you guys did a great job on this. There are some very wrong answers in this list, which none of you guys picked, but the majority of this list is correct, right? So obviously we're not gonna take cisplatin or Velcade, right? Those aren't really gonna do much for us. But dexamethasone's gonna do a lot, gauze and bandages. I love that some of you guys actually picked the pot to boil water because that's important. There you go, that's important too, right? We have to have clean, sterile fields for us to be able to take care of some of the things that happen. You know, if you're new to oncology and taking care of emergencies, that pocket guidebook for emergency medicine might be a really good source for you. So your jump bag is for you. It's meant to be what you think is gonna take care of the majority of your oncologic emergencies. All right, so you did it. You packed your bags. You made it to the Alaskan mountains, so it's been a relatively long plane ride. And you're like, it's not gonna happen on day 1, or is it? What do we think? Probably gonna happen on day 1, because otherwise we wouldn't have any fun while we were here. All right, so you're called to check in on a patient. You find a 55-year-old male with newly diagnosed multiple myeloma. He's recently started treatment, and this is his special trip for a stem cell transplant. He tells you he's just fine. I don't know why they called you to come see me. I'm fine, I'm fine, I'm fine. He's having some blood cramps, and he feels a little short of breath. What do you guys wanna do? Ooh, I love it. So you guys are too good for me. All right, so we're gonna do a review of systems. He's telling you he's having shortness of breath. He's having pain with inspiration. And then you say, let me take a peek at your legs. And you notice some left leg swelling, and it looks like this. All right, so what are our possible diagnoses? DVT, what else? PE, yes, excellent. All right, so we have a DVT, which is a deep venous thrombosis. The most common signs and symptoms are gonna be swelling, pain, warmth, and redness. I don't often get a D-dimer, but it's in the workup for it for a standard DVT. Now, the diagnosis for this, you're gonna make with a Doppler ultrasound, and then your big choice that you have to make is between proximal and distal. Can anybody tell me where the most common site for a DVT is? Distal, right, it's the popliteal vein, so right behind your knee. The second most common site is gonna be the femoral, which is in your groin. So really, when I'm seeing a patient in clinic, I'm actually gonna scan the whole leg, because a lot of our patients are gonna have multiple areas where they're gonna have blood clots. Now, we also said that he had a pulmonary embolism, and you would be correct. So the most common signs and symptoms for this are gonna be chest pain, this dyspnea and increasing dyspnea on exertion. So those of you who know me and work with me in clinic, you probably have often seen me walk a patient around in the rooms. And so if I have a patient that comes in and I'm worried about a DVT and a PE, then I'm actually taking them for a walk around the clinic. If their resting pulse came in at like 95, and their O2 is at 100%. We go on a little walk, and with minimal exertion, their heart rate's up to 125, and all of a sudden their O2 is decreasing the more and more we walk. In my mind, that's a PE until proven otherwise. How we diagnose a PE is going to be a CT chest PE protocol. Can anybody tell me the number one reason why we should not do a CT chest PE protocol? It's really going to be an allergy to the contrast eye. So a lot of us think renal insufficiency would be the number one reason, but really if they've got some minor renal insufficiency, and I'm talking about a creatinine less than 2, I'm going to push that CT scan PE protocol because that's going to give me the best chance of making the right diagnosis for a patient. We can give them fluids before and after the CT scan, and that's going to help protect their kidney function. If they have a true allergy to the contrast eye, then we can do a nuclear med like VQ scan. Those are really hard to get on a like that stat basis. The reads take a lot longer, and then sometimes they're actually wrong. So in the majority of cases, we really need to try to get that PE protocol. Now I'm going to put superior vena cava syndrome in here only because I think we should talk about it, because one of the reasons that we see superior vena cava syndrome can be when there's a big clot in the chest. This occurs when the blood flow back to the right atrium is blocked. The etiology includes tumors from lung cancer, lymphomas, or as the result of indwelling catheters. And as you guys well know, the majority of our patients have indwelling catheters. There are increased risks for such solid tumors like breast and thymic, but you can also see it in proliferative diseases such as sarcoidosis and infections like TB. The most common symptoms that you're going to see with SVC syndrome is this generalized swelling of their upper extremities, right? So it's really that left side that you're seeing. So you're coming in and you're looking at the patient, you can see all this distended vasculature through their chest wall. That's not supposed to look like that, right? And they just don't look right? They're kind of this grayish, bluish in color. They're telling you that they have to sit up straight. You're not going to lay them back, right? Because they can't breathe if you lay them back. They can be hoarse, they can have some difficulty swallowing. So this is another diagnosis that we just don't want to miss. So kind of back to blood clots, our cancer patients are hypercoagulable at baseline. They have a 5 to 7-fold increased risk of developing blood clots, and the greatest incidence is going to be in the period following diagnosis in that first 3 to 6 months. 0.5% of cancer patients will experience a DVT annually compared to 1% of incidence in the general population. And how do we treat these patients? We're going to put them on anticoagulation, and the choice of anticoagulation really is depending on what else is going on in their life, right? So if you have an AML patient that's coming in and they're on induction chemotherapy and they're more likely to have profound cytopenias, Lovenox or low molecular weight heparins are actually going to be your better choice because you can hold them much more quickly if they have that sudden drop in their counts. Also, they're more likely to be undergoing procedures like lumbar punctures, bone marrow biopsies, just easier to hold Lovenox than it is to hold the DOACs. However, for our patient here, our myeloma patient, I'm more likely to start him on a DOAC, which is really, in our case, we use mostly Xarelto and apixaban or Eliquis. It's oral, there's very few side effects. There's, if they're taken appropriately and we tell them what to watch out for, you can actually use these medications with a relatively low risk. So for our cancer patient here with multiple myeloma who has a blood clot, what's his number one risk factor is his diagnosis. What's his number 2 risk factor for why he developed this clot? Does anybody know? Say the flight? Yep. What would be another reason? Altitude. Give me another one. Think about his treatments. Who here takes care of myeloma patients? Oh, I'm a single one. Okay, it's the Revlimid. So we also have to think about the underlying treatments. There are certain of our medications that cause increased risk for blood clots. Your IMiD class, which is first-line therapy for multiple myeloma patients, is going to increase that risk. So just as we're seeing these patients and we're thinking about our oncologic emergencies, we need to think about not only doing the right diagnosis, doing the right treatment, but we also need to think about what other medications could be contributing to this as well. Now, are we going to start his Revlimid, stop his Revlimid? No, we're just going to treat the blood clot and we're going to keep going, but more than likely this patient's going to be on lifetime anticoagulation. So nice work. All right, so you've taken care of this one, you're just hanging out, and then somebody says, you need to go to the lake. I think there's somebody that needs your help. And when you go to the lake, you find your patient sitting down. It's a 46-year-old female with a history of breast cancer. She's not feeling well. She's telling you she's got some pain, some nausea. She's maybe a little bit confused, but not bad, and she's weak. So what do we want to do for our patient? Yeah, we're going to assess her and get some vital signs and get some labs. So we get labs on her. She's got a white blood cell count of 18.1, so that's elevated. We've got a hemoglobin of 10.7, but a normal platelet count. We get a CMP because we are on naked and afraid, and our labs and our MRIs and our CT scans come back like that, so it's amazing for us. It's that perfect world that we live in. Our creatinine is 1.25, which is relatively normal. Albumin is 3.3. Calcium is 14.1. LFTs are normal, and LDH is a little bit elevated at 286. So what do we have here? Yes, hypercalcemia of malignancy. So hypercalcemia of malignancy, we're going to kind of figure out how severe it is based on the serum levels of the calcium. So mild is that 10 to 11, kind of almost 12. Moderate is going to be 12 to almost 14, and severe is going to be greater than 14. So what did our patient have? Yeah, so they have severe hypercalcemia. And that's important to know because how I treat a patient for hypercalcemia is really going to depend on their serum calcium levels and their corresponding symptoms. So somebody who comes in who's completely asymptomatic and has a serum calcium maybe of high 10s, low 11s, I'm probably not going to treat the hypercalcemia, but I'm going to treat the underlying disease. So hypercalcemia is most commonly associated with malignancy. So this is not something when you show up in the emergency room and you have a newly diagnosed hypercalcemia that you're thinking of really other causes. Most of the cases are going to be due to some underlying disease. Breast cancer is actually one of the more common, in 30 to 40% of patients, with multiple myeloma coming in second, somewhere between 20 and 40. But really, you can see this in just about any of our malignancies. Non-Hodgkin's lymphoma, leukemia. Hypercalcemia can be an adverse prognostic factor, predicting shorter survival, but effective therapy for the hypercalcemia and the underlying cancer can improve outcomes. So why do we see this happen? So the most common reason is this humoral mechanism. So really what's happening is the receptors in the bones and the kidneys are causing enhanced bone reabsorption and calcium retention, so we're getting all that calcium building up in our bloodstream. And it results in symptoms. The most common symptoms that we're typically going to see is this kind of weakness. I've not really ever seen psychosis. Confusion is hit or miss, and usually they're just a little bit off, or maybe they're just kind of that slow to recall. You may see some arrhythmias, but the most common thing that you're going to see is nausea. Nausea, and more nausea. You may have some anorexia, which usually results in kind of not eating and drinking, and that's where we start seeing the renal failure. And then this profound fatigue. So they're telling you they've slept all night long, they're still tired, and they need to sleep more. So how do we treat this? We're going to water them like the little flowers they are. They need fluids, and more fluids. The number one therapy for hypercalcemia is going to be zoledronic acid or your Zometa. This is a bisphosphonate. The major contraindication for this would be severe renal failure, but even in renal failure, we tend to give zoledronic acid anyways, and we tend to give it at the higher doses to treat the hypercalcemia. If zoledronic acid is not available or cannot be used, we can use denosumab, still in that bisphosphonate category, but it's a monoclonal antibody, so it has a lesser effect on the kidneys. The downside with both of these drugs is they have a longer time for it to be active, so you still have some hypercalcemia while the drugs are doing their jobs. So if you have somebody that comes in with a lot of symptoms, their calcium is 14, then you can go ahead and start calcitonin. Calcitonin has a much shorter activity, so it gets in there, it works fast. The problem is it wears off quickly. And then you can use steroids. What you'll notice is not in this group is your loop diuretics. And so newer data that's coming out actually says that loop diuretics may be contraindicated in the use for hypercalcemia because they can actually worsen the renal failure and they can actually worsen the hypercalcemia. However, if you have patients that are volume overloaded, this still can be a viable option. The other big things to remember with our treatment choices here is denosumab can cause profound hypocalcemias. So when you're treating these patients with denosumab, you need to be monitoring their calciums, and it may seem counterproductive to give them calcium when they just came in with hypercalcemia, but you also can't have calcium levels of like 7 because then we're gonna have heart issues. So as with everything we do, it's always a balance, right? So finding that happy medium where they're stable and they're not having any symptoms and we're trying to correct the electrolytes. So fantastic job. You guys are experts in this. We've taken care of hypercalcemia, we've taken care of some blood clots, and now we're gonna keep moving about our day and we're gonna go on our first adventure. And so they said they wanted it and we're giving it to them and we're gonna go hiking. And I'm going to apologize now for the gratuitous use of my family photos throughout the rest of this talk. So I love a good mountain adventure. I do love the beach, but I do love the mountains, and I love a good day hiking. And so we're going to go hiking, and you're called to check in on a fall. And this is a 45-year-old male who states his legs just gave out him. He's fine. Keep going, keep going, keep going. You don't need to mess with me. While you're talking to him, he's like, no, I just have some numbness in my feet, right? We've all heard this before. He's like, I just lost my balance. So you guys are fine. Let's keep going. What do we think is going on here? Too good. You guys are too good. All right, upon further talking to him, he tells you he's got some bilateral leg weakness, and he has newly diagnosed prostate cancer. We're able to get an MRI, and it shows a T12 compression fracture. So you guys are absolutely correct. We now have spinal cord compression. Unlike hypercalcemia of malignancy, where it's almost always caused by an underlying cancer, we don't see that with spinal cord compression. Spinal cord compression can have other causes. So it can be caused by abscesses, it can be caused by degenerative disc disease. So only about 2 to 5% of cases are resultant from malignancy. It's most commonly seen in lung, prostate, and myeloma, and it generally has a poor prognosis with the exception of our heme malignancies, and that's because it makes the disease more advanced. The distribution, most commonly 70% of cases are going to be in the thoracic region, but about 38% of cases are going to be in multiple areas. And so it's important to remember that when you're seeing patients, we need to ask them where their pain is so that we can make sure that we're ordering the appropriate testing. So for spinal cord compression, the metastases occur in 1 to 3 locations. The most common is going to be in that vertebral location. That's going to be 85% of cases. Paravertebral is going to be surrounding it, and we have epidural, which is more rare. The number one mechanism of injury is really going to be that cord edema, and that's because that tumor is putting a lot of pressure there, and then you're getting swelling of that tumor around it, and that's putting more pressure, that's causing more of that cord compression. The symptoms most commonly is going to be back pain. That's going to be in 90% of patients. It can be this radicular pain that can start spreading down their legs. You can have progression to weakness and sensory changes in a matter of hours. So just the other day, we had a patient that came into clinic. I was like, oh, I don't like your symptoms. I was like, let's get an MRI, but they told me they couldn't do an MRI today. They can do it tomorrow morning. So I'm having a conversation with him, and I'm like, do you think you can wait until tomorrow morning? So I'm asking all the questions. I'm like, are you having any bladder or bowel dysfunction? He was like, no. And that's that saddle paresthesias. Don't ask anybody if they have saddle paresthesias, because they're like, I'm not a cowboy, I don't ride horses, right? And so some people would be like, saddle paresthesias, I don't even know where that is. So make sure we ask them if they're able to, or if they're having any accidents. So are they having loss of their bladder dysfunction? Are they incontinent? And he was like, no. I made him walk around the clinic. He was able to walk. He wasn't having a lot of overt symptoms, but he has multiple myeloma, right? This is in my clinic. And so I'm like, I still don't like your symptoms. I want to get an MRI. And I gave him the, if anything changes, if you start to feel like you're going to fall, if you're doing this, if, I want you in the emergency room. I saw him at 11 o'clock that day. By 5 o'clock that afternoon, he was in the emergency room, and he had a spinal cord compression, which I knew it, but I was just kind of working with what we have, right? And so in the retrospective scope, should I have done something different? I still don't think I would have. I had the MRI scheduled for that next morning. His symptoms weren't that bad, but it just goes to show how quickly these things can progress and how they can change. And that's an extreme example. I mean, I've got lots of other patients that have had MRIs 3 days later and they were fine. The most important prognostic factors is going to be that level of neurologic deficit and the start to treatment. And that promptness and initiation of treatment is really important, because what happens if we don't recognize it and we don't start treatment? Can they lose their ability to function and walk? Yeah, absolutely. So we can have permanent paralysis for these patients. You guys heard my talk last year. You heard me talk about my patient who they left her. She was in a COVID ward. They left her in there, sat on a spinal cord compression, and she was paralyzed afterwards. There was nothing they could do. And so again, reasons why I included this again this year. I think this one is so important, because if we don't recognize it and we don't take care of it, the long-term effects can be detrimental for these patients. So how are we going to take care of it? We need a diagnosis. We need to get a stat MRI. We want to try to do the entire spine if we can't. What's the number one reason why we can't do MRIs in our patient population? Say it again. So access, absolutely. What's another other reasons? Did somebody say metal? Yeah, metal on their chest. What's the other reason that everybody says they can't do an MRI? Yes, they're claustrophobic, right? Sometimes we got to force them through it, give them some Xanax, and have them go about their day. But the pacemakers is the biggest issue with our patients. So if somebody has a pacemaker, they can't have that stat MRI, right? Because they have to be in there with the cardiac units. They have to have the magnets that can check it before and after and ensure the pacemaker is functioning appropriately. So if you can't get a stat MRI, then you can do a CT myelogram. And then we need to be making phone calls to our friends. So we need to be calling neurosurgery and need to be calling radiation oncology. Mainstays of treatment, steroids, and more steroids. For most of our patients, we're starting them on steroids, and then we're usually sending them to radiation to get quick debulking of that tumor that's causing us issues. The steroids improve that neurologic function because they're good for that edema. So after we start it, they're getting some reduction of the edema, which actually can help with some of the symptoms. But overall, the kind of mechanism why steroids work is a little bit unclear, but we love them, they work well, so we're going to continue to use them. We're going to consider surgery if those neurologic deterioration is at a previously treated level of radiation or deterioration with radiation and high-dose steroids. And so I just recently had a patient, I know this is why you guys love having me come because I see this all the time, is I had a patient that I was able to get her MRI the next day and she was fine, but when the spine doctor read it, they said, oh my goodness, you cannot go home, you're going in right now, and immediately took her to surgery because of where her level was, and she was T11. He was actually worried that if it went a day or two longer, she was going to be paralyzed. And so that's kind of that other example. A lot of times I say, I'm like, I don't really see neurosurgery get that much involved. Well, I'm starting to see it a little bit more. And I don't know if the patients that I'm seeing are just a little bit sicker recently, or if that's just kind of where I'm at in my practice for right now. But definitely want to make sure that we get neurosurgery involved. All right, so good job. So spinal cord compression, got some DVTs taken care of. You've seen your hypercalcemia. You're like, I'm done for the day, right? Not doing any more of this. I'm walking away from everybody else because they don't need me right now, and I'm going to take a selfie in front of the waterfall because it's really, really pretty. But you notice one of your older patients is acting just a little bit confused, and you can't help yourself, right? You've got to go over and find out what's going on. She's been drinking a lot of water. She has a history of small cell lung cancer. So what do you guys think is going on? Good job. All right, so we're gonna work her up first though. So we do an exam. She's got crackles in her lungs. She's tachycardic. She's 125, so not too bad. You guys are outside. You've been walking around. Blood pressure's 112/52. A little soft, but not bad. Let's get some labs. Glucose is 225. Creatinine's 1.65. Baseline's around 1.5. Potassium's 3.4. Sodium is 122. And the urine shows no leukocytes or nitrates. But you're like, you know what? She's got these crackles in her lungs. Let's get a chest x-ray. And it looks like this. Now, what do you guys think is going on? Say it again. Yeah, so we got pneumonia, and you guys were right the first time. We still have SIADH or delusional hyponatremia. So this is defined as a serum sodium level less than 135. The most likely causes pneumonia. Brain metastases can also cause it, and then we have to think about what they're being treated with, right? So cisplatin, cyclophosphamide, methotrexate are common causes of SIADH. But also, what else has been going on? Are they nauseous? Have they been vomiting? Are they having a lot of diarrhea? So those symptoms can contribute to the hyponatremia as well. Then we need to think about what other medications that they're on. The SSRIs are the most common that we see in our clinics that can be contributing to delusional hyponatremia. How do we treat it? The volume should be assessed and corrected. Most of the time we tell them to limit that free water intake. And you're gonna see in the literature anywhere between restrictions to 500 milliliters per day up to 1,500 milliliters per day. I go somewhere in between that, just kind of depending on our patients. Our patients are generally sick. They need some water, right? We can't have them becoming dehydrated because they're not drinking anything. But this is where we want to promote our liquid IVs. We want to give them Gatorade. We want to give them broths. Or sometimes I actually have them add salt to their water too. Add a teaspoon of salt. They don't really like me when I tell them to do that, but they understand why it's happening. For severe hyponatremia, which is defined as the presence of neurologic symptoms, this should be treated with hypertonic saline solution, and this is generally done where? Yeah, in the ICU, right? Because this is where we don't want anything bad and we like our brains intact. So nice work, everybody. So you've done it. You've taken care of everybody. You're amazing. We've taken care of all of our oncologic emergencies, and now we're gonna hang out around the campfire. And we're gonna make some s'mores. And whilst making some s'mores, you're talking to a 65-year-old male with a history of AML, and he's in CR1. So he's in a complete response. He's not on therapy anymore, and that's why he's on this trip. He tells you he's been having some fevers, he's having some shortness of breath, he's dizzy, and he's got some blurry vision. So what do we think is going on here? What do you guys think? I'm stumping you this time. All right, so let's get some labs. His white blood cell count is 100,000. His hemoglobin's 8.5. His platelet count is 12. His creatinine's normal. His LFTs are normal. His LDH is elevated at 500. Potassium is just a little bit low at 3. Magnesium is 1.8, a little low. Calcium's normal at 9. His uric acid is 7. His D-dimer is 800, which is elevated. Fibrinogen's 100, which is a little bit decreased. Say it again. Oh, yes, DIC. What else? There's multiple things going on here, right? Say it again. Tumor lysis may or may not be right. We're going to talk about that one. What else do we think it is? Yeah, he's got relapse disease, right? His white blood cell count is 100,000. So for tumor, he may not qualify for technical tumor lysis syndrome right now, right? Because for tumor lysis syndrome, it is hyperkalemia and it's hypocalcemia. And so even though his uric acid is elevated, technically right this minute he doesn't have tumor lysis syndrome. He probably will in a couple of days, but right now he does not. On imaging, we get a chest x-ray. We're gonna get a CT scan of his head, right? He's telling us he's having some dizziness. And his chest x-ray shows all this kind of infiltrates and stranding that we commonly see with what diagnosis? It's the hyperleukocytosis. So hyperleukocytosis needs to be treated with rapid cytoreduction with induction chemotherapy. These patients, the recognition of the hyperleukocytosis is the most important thing that you can do, because the failure to recognize this, which I don't think anybody's going to miss this, can worsen prognosis. Anybody who has a white blood cell count greater than 50,000, prognosis is already going down at that point. We can use hydroxyurea in asymptomatic patients. We can do leukapheresis in symptomatic patients or white blood cell counts greater than 100,000. But remember, leukapheresis and hydroxyurea can be contraindicated in our APL patients because it actually can worsen our can worsen our DIC. This patient also has DIC, which is disseminated intravascular coagulation. The diagnosis is made by thrombocytopenia, elevated D-dimer, decreased fibrinogen, and prolongation of the clotting times. Now, DIC is not only just seen as in cancer patients, right? We can see it in our pregnant patients, we can see it in our septic patients, but this is important that we recognize it and we take care of it, because failure to do so can cause detrimental effects, like with everything that we're seeing here. How we're gonna treat it, you've gotta treat the underlying disease most importantly. We can give them transfusions, you can do fresh frozen plasma, and you can give them fibrinogen. Now, our patient here, we knew he had a history of AML. He was in CR1. He's coming in, we're seeing all these lab changes, but before you get all your labs back, you're going through your differential diagnosis. And you're like, maybe this is something else. Could this be hyperviscosity syndrome? So hyperviscosity syndrome is not usually seen in our leukemia patients, but it's more commonly seen in Waldenstrom's microglobulinemia. We can see it in lymphomas, and we can see it in multiple myeloma patients. And so the classic presentation for hyperviscosity syndrome is going to be these vision changes, right? And dizziness, which he all had. So as we're going through and figuring out what's going on, we've got to make sure that we're not missing any other diagnosis, and we're ruling out other reasons for having some of these symptoms. How do we treat hyperviscosity syndrome? Is we're going to reduce the protein levels, so we've got to treat the underlying disease as with everything. We can also use plasma exchange to treat hyperviscosity syndrome. And so typically with hyperviscosity syndrome, you're looking at the algorithm here. So are they symptomatic? Do they have highly specific symptoms or no? And what is their underlying protein level? So what you'll commonly see, and I'm sure you've all seen this in your infusion centers and your clinics, for a lot of our Waldenstrom patients and our myeloma patients, we may be monitoring viscosity levels, but depending on the viscosity levels and depending on the symptoms, we may not be doing anything but continue to treat the underlying symptoms. For our patients who presented with hyperviscosity syndrome, we can continue to monitor those viscosity levels, because if all of a sudden the viscosity levels trending back up again after successful treatment, you're worried about disease relapse in those settings. The important part of recognizing hyperviscosity syndrome is that if you miss the diagnosis for this, then you've compromised their vision for these patients, because most of these patients, as it continues to worsen, can actually start having hemorrhages in their eyes, and they actually can go blind. Successful treatment of this and recognition of the symptoms and getting them into their ophthalmologist and having those continued exams, you actually can go back to baseline. So we had patients, right? I've got a story for everything. I've had a patient that presented with multiple myeloma. She didn't know she had myeloma. She came in with vision changes. That's how we diagnosed her. She actually was losing her right eye vision, and her right eye, she's not perfect and hasn't been perfect. She wears glasses, and now her vision's back at what her baseline is with successful treatment of her underlying disease. And she also got plasma exchange as part of her induction therapy. So I wanted to include that this year because it's something that we didn't include last year. So just trying to increase the overall knowledge for all the different oncologic emergencies that are out there. All right, so we went to bed, we had a good night. We're like, I am the best medical provider ever because I can take care of everything. And now we're gonna go mountain biking. And while we're out mountain biking, somebody pulls this off of their arm. They're like, I'm fine. And then a little bit later, they have this. What is this? I love the answers for Rocky Mountain spotted fever. It's my favorite. It's actually urticaria. These are hives. So she has a tick bite. She's complaining of burning in the area. She's got worsening hives that are spreading. And then all of a sudden she starts coughing. She's reporting shortness of breath. She's nauseated. And she's like, I don't feel good. I really don't feel good. I feel like something bad's going to happen to me. So what do we have here? Say it loud and proud. There we go. So things that I feel like I have to include to this group every single year is we've got to talk about hypersensitivity reactions, because you guys do this so much more than I do. And this is what you guys see on a daily basis, right? So hypersensitivity reactions, or these anaphylactic type reactions, are graded as mild, moderate, and severe. If you're in an infusion center and you're running a medication and somebody's having a reaction, what's the very first thing that you guys should all do? Love it. Stop the infusion. And usually when you guys call me over for this, the very first thing out of my mouth is, did you stop the infusion? I'm not trying to be insulting when I say it's my own gut check, because that's the things that are going through my head to make sure that we've done all these things. Because early in my career, I run over to do this, and I was not at Emory, I was somewhere else. And we're doing all the things that we're supposed to do, and I look over and the drug is still running. I had never said to stop the drug. So again, this is my own, gotta run through my things. We all learn by mistakes that we've made in our past. So stop the infusion. We're gonna give some Benadryl, we're gonna give some famotidine, and we're gonna water them like the little flowers that they are. Now, does our patient have a mild hypersensitivity reaction? No, because she has urticaria, right? So mild is in the absence of dyspnea, which she's telling you she's short of breath, but they also don't have hives. So a moderate hypersensitivity reaction occurs with the following symptoms. So now we have dyspnea, but we're maintaining a O2 greater than 90%. They can have some flushing. We've got some urticaria, but we're still not hypotensive in this. In this setting, this is where we're gonna add in this hydrocortisone, so we still stop the offending agent. We give them some Benadryl, we give them some Pepsid. We started in hydrocortisone. Hydrocortisone is 100 milligrams IV push over at least 30 seconds times one dose. And enough of you have worked with me. I love hydrocortisone, so I usually repeat it if we're not getting the adequate response. You're gonna maintain your fluids, and we're gonna keep an eye on these patients. For a mild or moderate hypersensitivity reaction, if their reactions resolve and they're feeling better, are you gonna re-challenge them from their drugs? Of course, right? Most important thing is that we treat the underlying disease, so we want to re-challenge and keep them going. The one time where we're not going to re-challenge is in a true anaphylaxis or the severe hypersensitivity reaction. So anaphylaxis is defined as an acute deterioration of the mental status. You have loss of consciousness. You're going to angioedema, which is swelling of your lips. There can be febrile at this point, and we're starting to see more respiratory distress. So O2 is less than 90%. They may have some stridor, and this is that ever important tongue and throat edema. Why do we want to make sure that they're not having that? Because we need to protect their what? Airways, absolutely. What's the other most important thing that we do when somebody is having a severe hypersensitivity reaction? EpiPen, absolutely. So we want to get an EpiPen. That's the number one thing that we should be doing. So stab that into their big muscles of their legs. And then we can give them still Benadryl. We're going to give them some steroids. We're going to give them famotidine. And then in our infusion centers, we have the ability to do albuterol nebulizers or even racemic epinephrine. And the other ever most important thing is get them out of there, right? So we've called 911 or we've called our codes and we're getting them out of our clinics, because the downside with anaphylactic reactions is they can continue to have these little minor reactions, right? As that drug or the offending agent, whatever cause it is, leaving their system, all those toxins are getting out of their system, they can continue to have these symptoms. And so they need to be having more monitoring. They need to get out of our clinics and they need to be in the emergency room, because we love them, but we don't want them there anymore. All right. Again, gratuitous uses of my family photos. That's my daughter, Kendall. She's the love of my life. My husband comes in second. Just kidding. Now this is recorded for perpetuity. I love it. So now we're going on a hike, and it's the final hike of the trip. And you're called over to check on a patient, and this is this wife, and we have all seen them, right? They're coming to you even though he's got no complaints in the world. And the wife states that her husband's been complaining of a headache times 3 days, and he's like, I'm fine. It's just the altitude. I'm fine. This is a 48-year-old male with a history of melanoma, and he's been in remission for over 2 years. He's like, maybe I'm a little bit nauseous, but I'm fine, right? So how are we going to work this up? What do you guys think this is? Ooh, okay, good. All right, so we're going to work him up. His exam is essentially normal. Blood pressure's normal, his lungs are clear, but he's got a little tremor in his right hand. I don't know if you guys can see me, but I'm going to twitch my right eye while I'm talking to you. So he's twitching his eye and he's twitching his hand, and he doesn't really realize that he's doing it. We get some labs, perfectly normal. Do you guys want to do anything else? Yeah, let's get some scans. So he's telling you he's having headaches for the last 3 days. So the worst thing that I want to make sure I'm not going to miss is a bleed in their head, right? So I order a CT scan of his head, shows no evidence of a bleed. So then we're going to move on to an MRI. And now we have a new lesion on the right occipital lobe with mass effect and edema. So what does he have? Right. So we've got brain metastases. So brain metastases are the most common intracranial tumors in adults. This is 10 times more frequent than we see in primary brain tumors. It happens in about 20 to 40% of all cancer patients, and this number unfortunately is growing a little bit. Most commonly seen in our lung cancer, breast cancer, and our melanoma patients. The location is mostly in this, 80% of these are in the cerebral hemisphere, which is that boundary between the cortex and the white matter. 53% of patients are going to have multiple lesions. Even though this is typically not a good sign, treatment offers palliation and extension of life, and that's what we want for our patients, right? We want to make their symptoms better, and whatever life that we can give them, we want to make sure we're doing for them. The pathophysiology is that destruction and displacement of the normal parenchyma, and then you're going to get edema, and it causes increased intracranial pressure, which is a lot of that nausea that you're going to see. 70% of patients are going to present with headaches. About 50% are going to have neurologic deficits, and you're going to see seizures in about 20% of patients. So he's got his twitch. What do we think is happening? Seizures, right? So he's got focal seizures. Your best diagnostic test is going to be that contrasted MRI, right? Because if we don't give them contrast, we miss that diagnosis. So if they can't have MRIs because they're claustrophobic or they've got pacemakers, then you want to make sure you're getting a contrasted CT scan, because a non-contrast is going to miss that tumor every time. How are we going to manage this? We're going to go with my favorite drug, right? Steroids, and more steroids, and divided doses. For the seizures, we can start them on Ativan or lorazepam. And then this is our patients that we want to make sure we're getting our colleagues in radiation oncology involved, because they may need radiation therapy, may or may not need neurosurgery. It just depends on where the tumor is located. Whole brain radiation, especially with multiple metastases, the symptoms are going to improve in over 80% of patients. So this is good for our patients, even though they may not like having to go through it. Most of the time, we're seeing symptoms improve in about 3 weeks, and we're going to have a median survival, increased survival by giving them radiation for somewhere between 3 and 6 months. And as you guys all well know, 3 to 6 months can be a lifetime with our patients. So anything that we can do, we want to do for our patients. Leptomeningeal metastases is kind of that brain mets on steroids, or on crack, as I like to say, right? It's now left the brain and it's gone all the way down the spinal column. This happens in about 5 to 8% of solid tumor patients, and the literature is actually showing this is starting to increase. They present with multifactorial neurologic dysfunction. So we've got infiltration of the brain parenchyma And typically you're going to see it in the spinal cord as well too. You've got infiltration of the cranial nerves and the spinal roots. You've got interruption of the cerebrospinal fluid absorption, and you can have brain ischemia and cerebral infarction that happens with this. The most common reasons for this is going to be in our leukemic and our lymphoma patients, but I've seen it in breast cancer patients. You can see it in lung cancer, breast cancer, and melanomas, and this unfortunately carries our poorest prognosis. So these are the patients that typically when you see them and you come into clinic and they're like walking like this, right? And they don't realize they're doing it until they hit the wall, right? Or they're off, right? They're kind of, they don't even realize they're doing it, but their family members do. And that's why it's so important to pay attention to how our patients walk, because he may never have had a single complaint, but if you're paying attention to him, that you can see some of these subtle changes. The presentation for this is going to be headaches, a lot of nausea, a lot of vomiting. So if you've got that patient that comes in and you've thrown everything at them to treat their nausea and it's not getting better, that's when we need to go looking for other causes. It's when we need to start ordering our MRIs. You got to get that contrasted MRI because that's really how they're going to see that leptin meningeal enhancement. And for most of these patients, we're going to do an LP on them. And that's because we need to make sure that we're diagnosing the right thing, right? So our breast cancer patients can have secondary leukemias. So even though we think it might be breast cancer, they are at risk for having other things. And so we want to make sure that we're checking for the cytology and make sure that we're getting the right diagnosis so that we're treating the underlying disease correctly. The treatment for this can be cranial spinal radiation and intrathecal chemotherapy. Patients hate the cranial spinal radiation. They do. It has lots and lots of side effects, and the side effects are sad for them, right? They can have word finding issues. It can affect their speech. It affects their memory. And so I've had patients flat out refuse it, and that's their choice to make, right? Same thing with the intrathecal chemotherapy. They're hard on patients. They're hard on those of us that do it, right? Over time, it's harder and harder to stick that needle and to get into that space. And also giving them chemotherapy in there can have side effects as well too. And it can be some of those similar side effects with that memory loss. And we've had patients just say, I'm not doing it anymore. I'm okay with the outcome. I know what it means, and I'm okay with that. And we should be okay with that as well too. That's their choice. We guide them in the right directions. We try to offer them the best care. But at the end of the day, we have to respect the decisions that are being made. You did it! Nice work, everybody. So you guys have taken care of this year, right? So I told you we weren't going to do tumor lysis because I think you guys can all diagnose that in your sleep and know you can diagnose neutropenia in your sleep. But this year we talked about hyperviscosity syndrome, we talked about DIC, talked about brain metastases, and we did blood clots, which were new this year. So it's the end of the year party. I love trivia. So you're going to your local bar and restaurant and you're going to play some trivia. And it's never quite over, is it? You're sitting next to a lovely 67-year-old gentleman who has struck up a conversation with you. He's telling you that he has relapsed refractory diffuse large B-cell lymphoma. He's been receiving treatment with a novel agent so long that no one can say it, much less spell it. His wife comes back and looks at her husband and says, "How you doing?" They're just, being overbearing, making sure that they're okay. They've got their thermometers in their purse, and they're going to take it out. He's like, "I'm fine." She checks his temperature anyway. Temperature is 100.4, not febrile, right? Not in our land. It's getting close there, but we like that 100.5 and higher. One of the other passengers is nosy, right? Because they're all nosy. We're all nosy. We can't help ourselves. And they're listening and says, "Don't worry. You guys have got this, right? You've taken care of everything that's been thrown at you, and you've got this. You're here to save the day." So your next steps, you're going to do a physical exam. You're going to do a neuro exam because he just told you it's a novel agent with a name that he can't spell or pronounce, and we all know what those are, right? Because they're giving me troubles. I'm liking all the acronyms that we're giving things these days. It makes my life easy. We're going to check some labs, IL-6, ferritin, CRP, and we're going to check some the clotting. And do we want to do some imaging? Maybe or maybe not. What do you guys think he has? Absolutely, yep. And so he's got CRS, most likely related to bispecific therapy. So bispecifics are our newest therapy that are coming to the market. These are antibodies that are diverse. They recognize 2 antigens, and most are designed to activate CD3 and the cytotoxic T cells against a specific tumor target. There's currently 4 in the market. They're approved for diffuse large B-cell. We have 2 for multiple myeloma, and we have got 1 for ALL. There's going to be more of these, and so that's why I know we did this last year, but I wanted to do it again this year because this is the hottest drug that's out there. They're in trials for melanoma and lung cancer, and I'm sure we're going to start seeing it in our other solid tumor malignancies as well. So it's important that you guys know the drugs, may or may not be able to spell them, that's okay, but be able to take care of the symptoms that go along with them. So cytokine release syndrome is an acute systemic inflammatory syndrome characterized by fever and multiple organ dysfunction, and it's most often caused by immunotherapy. So we see it in our CAR-T patients, and we're going to see it in our bispecific patients. You can have the immune effector cell neurotoxicity, which is our ICANS, which is encephalopathy syndrome that occurs with these patients as well. How we grade it is based on the level of hypotension and the level of hypoxia. And so the greater that is, the greater the grade is, and the more that we do for these patients. Same thing with the ICANS. It's the level of disorientation and cognitive impairment. This one makes me laugh the most. Melody's probably gonna giggle at me. I say our patients on a good day are probably a 7 out of 10 anyways, but we still make them go through all of this testing anyway. So we're asking them, do they know you where you are? My ultimate favorite is, can you count back from 100 by 10? I'm not always sure I can do that on my best days, but and every time a patient misses something, then that 10 out of 10 score goes down, and that increases their level of impairment. How are we gonna treat this? We're gonna give them Toci. It's administered intravenously over an hour. You can give up to 4 doses in 24 hours, but most of the time we usually do not exceed 3 doses in 24 hours. I'm looking over at Melody to make sure I'm right. So the bispecifics have some unique side effects associated with them. They carry an increased risk for infections. You can have injection site reactions. I'm sure you guys are seeing this in your infusion centers as we use them more and more. Hypogammaglobulinemia is seen in these patients. We actually don't mind seeing the hypogammaglobulinemia as much because you actually know the medication's working. So if they're not dropping their IgG levels, you're like, uh-oh, I'm not sure this is doing what I want it to do. We can see rash, change in taste, hair loss, and nail changes. And that's it. Congratulations, you guys did it again. You guys made it through everybody's emergencies. I appreciate you guys all taking time to come and listen to me. I hope you found it useful. Try to be a little bit entertaining because I know it is at the end of the day, and I think me and one other person stands between you guys going home. Does anybody have any questions for me? Nope. Well, it's a pleasure to see you guys all here. I hope you enjoy the remainder of your conference. I'll stick around for a few minutes if anybody has any additional questions. Thank you and have a good rest of your weekend.